Okay.
Hello, everyone. Thank you for joining me today. My name is Dr. Tanushri Bhushan, and today I'm going to present on narcolepsy and the importance of the early diagnosis. So this is just an outline. First, I'm going to talk about the case, introduction, pathophysiology, epidemiology, clinical features, importance of early diagnosis, diagnostic evaluation, differential diagnosis, treatment, fast facts about narcolepsy, and a little quiz in the end. So a 37-year-old female brought to the clinic by her son with clinical feature of chronic fatigue, exhaustion, tiredness, headache, daytime sleepiness, and fainting spells from November 2020. Patient reported that headaches are pressure-like, 7 in 10 in intensity, non-radiating, partially relieved with acetaminophen, no aggravating factors. She has had 4 syncopal episodes, and the last episode was 4 months ago and was admitted to the ED for the same. The syncopal episodes are sudden, preceded by ringing sensation in ears, warmth in the body, and not associated with postural change, emotional triggers, cough, or sneezing. She visited ENT specialists for the fainting spells, but all tests were normal. She also complains of vivid dreams, insomnia, frequent daytime naps. She has been avoiding driving and heavy weight exercise from the last year due to her signs and symptoms. She denies nausea, vomiting, palpitation, recent infection, head injury. Her recent MRI of head and echocardiogram was normal. In the review of system, everything was normal except she complained of weight gain, approximately 10 pounds. Past medical history, she's been diagnosed with Eagle syndrome, and nothing was done for that because it was very mild. Cervical cancer during birth of the second child, and LEAP was done at that time. Menstrual history, she also complains of menstrual irregularities since August 2020. She's been taking multivitamins and melatonin. Physical examination, everything was normal. She was oriented to place, person, and time. Pupils were round, equal, reactive to light. In the neurological examination, everything was normal except the Romberg sign was positive. Her vital signs were within normal limits. Epworth sleepiness scale was 16. What was the differential diagnosis? Narcolepsy, obstructive sleep apnea, hypothyroid, or cerebellar dysfunction. The plan was to get the EEG, polysomnography, and electronystymography. So little introduction about the narcolepsy. So narcolepsy, which is also known as Gerignon syndrome, which is named after the French neurologist. It was also known as hypnolepsy, narcoleptic syndrome, or paroxysmal sleep. It is a chronic neurological disorder that severely disrupts the body sleep and wake cycle. It is characterized by extreme daytime drowsiness. It is one of the most common causes of disabling daytime sleepiness after obstructive sleep apnea. Now the pathophysiology. So we have the specialized neurons in the lateral hypothalamus, which actually stabilize our wakefulness and sleep. These neurons secrete a molecule which is known as hypocretin 1 or 2 or orexin A or B. So what is the role of these molecules or these neurons? It helps you to stay alert. So the primary role of orexin is to control sleep and arousal. The neurons that release orexin are most active during the day. To keep us awake, the neuropeptide stimulates other neurons to release neurotransmitters that promote alertness, such as dopamine, serotonin, and norepinephrine. So what happens when these neurons get damaged or there's deficiency of orexin A or B? You feel sleepy. So the loss of the lateral hypothalamic neurons, which produce orexin A and B, cause severe deficiency of orexin deficiency, and that cause dysregulation of sleep and wake cycle. The exact etiology is unknown, but the genetic and environmental factors seems to be implicated. Genetic predisposition as the narcolepsy type 1, especially, is strongly associated with the variation of HLA-DQB1 gene, called as HLA-DQB10602. It is also associated with strong family history and, interestingly, the environmental factors like streptococcal pharyngitis or exposure to the H1N1 influenza antigen during vaccination. So in 2009, 2010, when there was pandemic of H1N1, in European countries, they used this vaccine called pandemics, which was given to people. And after that, there was a spike of narcolepsy. And it was thought that it is because of the autoimmune cross-reactivity. So currently, there are speculation in this pandemic of COVID-19 that COVID-19 infection itself can cause narcolepsy or maybe the vaccine, but this is still under research. But I won't be surprised there can be a similar thing can happen with COVID-19 and there will be a spike. How common is narcolepsy? In the United States, narcolepsy affects 1 out of 2,000 Americans. Interestingly, this is more prevalent in Japan. The narcolepsy in Japan is 1 out of 600. Why is that? Is it because the environmental factors are different or the genetics are different? Or it could be that they are coming out and talking about sleep disorders. And that's how we are documenting more narcolepsy case there. The prevalence, the incidence is about 0.74 per 100,000 person year. It is equally common in male and females. And it is more common in the age of between 10 to 30, but narcolepsy can occur at any age. It is estimated that only 25% of people who have narcolepsy have been diagnosed and are receiving treatment. Now coming to the clinical features. The most common clinical feature that you can see in narcolepsy is excessive daytime sleepiness. All patients with narcolepsy have chronic sleepiness. They do not sleep more than healthy individuals during a 24-hour period. They are prone to fall asleep throughout the day, often at inappropriate times. Even like 15 minutes of nap, they feel refreshed and alert. The second most common is cataplexy. So I've not mainly focused on the type, but we do have 3 types of narcolepsy, and cataplexy is more common in type 1 rather than type 2. So cataplexy is emotionally triggered transient muscle weakness. It is an episode, may also trigger after anger or grief, but it is more common after laughing at a joke or winning a game. It usually affects the head and neck area, but if it is more severe, the patient can actually collapse. And it is very important physically and mentally for these patients who are experiencing cataplexy, is because now if they collapse, they can injure themselves. And mentally and socially is because they avoid gathering. They avoid going to family gathering or birthday parties because they feel embarrassed of cataplexy. Cataplexy develops within 3 to 5 years of onset of sleepiness in 60% of the people with narcolepsy. Now, the third most common symptoms that you can find in narcolepsy is hallucination. These hallucinations can be vivid, frightening, can be visual, tactile, or auditory hallucination. If these type of hallucination happens when a person is going to sleep, it is called hypnagogic hallucinations. And the same hallucinations, if happens upon awakening, it is called hypnopompic. I remember like that. Hypnagogic is geo, that's why I've made it capital. It's when you're going to sleep. And then hypnopompic is like pumping out of the bed. So that's how I remember. They probably result from a mixture of the wakefulness and the dreaming of the rapid eye movement sleep. Now, the fourth is the sleep paralysis. The sleep paralysis is the complete inability to move for 1 or 2 minutes immediately after awakening. It may also occur just before falling asleep. The immobility may be accompanied by hypnopompic hallucination or a sensation of suffocation. Now, patients who are experiencing this are very scared because they are paralyzed, and these hallucinations are so real that they can actually see some animal in their room or a person standing in their room, but they cannot get up for like 1 or 2 minutes. So it is a very scary experience for these patients. So I just want to differentiate between a normal sleeper and narcolepsy, what they experience. In normal sleep, what happens? When you start out, you actually started in a non-REM sleep, and it takes about 60 to 90 minutes to enter the REM sleep. REM sleep is the rapid eye movement in which you dream. How it is different from narcolepsy? In narcolepsy, you sleep quickly within 5 minutes. And therefore, you enter the REM sleep within 15 minutes. And because of that, these patients experience vivid dreams. Now, I'm going to show you a clip of cataplexy to give you an idea what they experience. You can see this patient that there's a jaw dropping, maybe she was laughing, head slumping, and now within a second, she'll be normal. She's alert now. So these patients, they experience in a normal, if they say that it's a good day, they experience this kind of episode around 10 to 15 times. And if it is a bad day, they can have up to 40 times. So you can imagine like how exhausting it is. Other clinical features, fragmented sleep. Patients with narcolepsy generally fall asleep rapidly, but can spontaneously awaken several times during the night and have difficulty returning to sleep. Other sleep disorders can overlap with narcolepsy, such as obstructive sleep apnea and periodic limb movement of sleep, restless leg syndrome, REM sleep behavior disorder, sleepwalking. And it can also, the patient can also have depression, anxiety, ADHD. So why it is so important to diagnose narcolepsy so early? It is very rare that the patient experience all 4 symptoms. Like I said before, they have the most common symptom is excessive daytime sleepiness. They cannot have cataplexy at all. So that's why it is important. Another thing is that, like the patient who came to the clinic, she was just complaining about fatigue, tiredness, exhaustion. And these type of symptoms are very, very common in other disorders. So it is misdiagnosed very commonly. In the recent study, 60% of the patients were misdiagnosed. The most common misdiagnosis was depression. Almost 1/3 of the patient was misdiagnosed as depression, followed by insomnia and obstructive sleep apnea. On an average, it can take about 6 years to diagnose narcolepsy. A misdiagnosis of narcolepsy has long-term implications such as limited employment option, unnecessary use of prescription, insurance-related issues, and inability to drive. According to Harvard Health, the prognosis of narcolepsy is bleak if the disease is not managed correctly, namely because narcoleptics are at much higher risk of work-related injuries or motor vehicle accident than members of the general population. So that's why it is very important to do early diagnosis. How will you diagnose narcolepsy? Clinical assessment. So what do I mean by clinical assessment? Proper history taking. We have learned in neurology that the history taking is very important. But in narcolepsy, it is very important to have the sleep history as well. Asking few questions like, are you sleepy most of the day? Do you feel rested upon waking in the morning? Do you have vivid dreams during daytime naps? If the answer to all these questions is yes, then you need to do further studies. And we do have an Epworth sleepiness scale. And it says that if it is more than 10, you should suspect sleep disorder and do further sleep study. And of course, the physical examination, especially if a patient is experiencing cataplexy, hypnagogic or hypnopompic hallucination or sleep paralysis, then we have to do proper physical examination. And the sleep studies, we have 2 sleep studies. One is polysomnography, and the second one is multiple sleep latency test. The polysomnography patient with narcolepsy type 1 and occasionally those with narcolepsy type 2 may show REM sleep within 15 minutes of the onset of sleep. And the multiple sleep latency test, each nap session continues for 15 minutes after sleep onset to detect REM sleep. The sleep latency is documented for each nap session. So it says that MSLT is positive when an average sleep latency is less than or equal to 8 minutes and or at least 2 sleep onset of rapid eye movements. Now coming to the differential diagnosis, like I said, it overlaps and you can misdiagnose narcolepsy. So it is very important to just focus on the differential diagnosis. I've highlighted the most important one, which is insufficient sleep, obstructive sleep apnea, delayed sleep phase disorder, idiopathic hypersomnia, and depression. In the obstructive sleep apnea, you should ask about snoring, if there are episodes of apnea in the examination, if you see large tonsils, large tongue, long uvula, or if the patient is obese, then you suspect obstructive sleep apnea. And depression, you need to ask if there's increased time in the bed, but little functional sleepiness on the multiple sleep latency test. So these are the differential diagnoses that we should keep in mind when a patient comes with the daytime sleepiness. Now coming to the treatment. Currently, there's no cure for narcolepsy. What we can do is that we can give the stimulants and do lifestyle modification for our patients. So the first initial and most commonly used is morphine. It reduces the daytime drowsiness and improve alertness. And it is prescribed first because it is less addictive and has fewer side effects as compared to the other stimulants. Then antidepressant. So there are like 2 classes of antidepressant that we can use in narcolepsy, controlling the cataplexy in these individuals is tricycline and SNRIs. And the last one is sodium oxybate. It has been approved by US Food and Drug Administration to treat cataplexy and excessive daytime sleepiness. The only issue with this drug is that it is strong sedative and then you have to take twice at night. Other lifestyle modifications we can do, we can tell the patient to take short naps, maintain a regular sleep schedule, going to bed and waking up at the same time every day. Same time every day, even on the weekends, can help people sleep better. We should suggest our patient that they should avoid caffeine, alcohol before bed, even avoid smoking. Exercise daily. It is seen in narcolepsy patients if they exercise 20 minutes per day, it can help them. Avoid large meals right before the bedtime. Relax before the bed. Maybe some relaxing activities like a warm bath, and then safety precautions. As soon as you suspect or diagnose the case of narcolepsy, you should suggest your patients that they should avoid driving because they can go into an accident. The American with Disability Act require all the employers to provide reasonable accommodation for the patient, such as modify their work schedules. And the support groups. The support group is very, very important because, like I said earlier during the clinical features, that if they're experiencing cataplexy, for them, it is an embarrassment. So if they talk to people who are experiencing same type of signs and symptoms, then they'll feel much better. Now, some fast facts about narcolepsy. I've talked about narcolepsy, that it is difficult to diagnose, but there was this study done, and about 2 out of 3 people with narcolepsy have cataplexy. Yet the survey found only 26% reported it. So it is very less number. 54% reported knowing little about cataplexy, and 58% said that they are clumsy and tend to drop things more than other people, but did not cite cataplexy as a symptoms. So what we learn from this, that there should be more awareness about narcolepsy and these symptoms, because in the recent studies, it showed that lower awareness and misperception, there is an average delay of 8 to even 15 years between the narcolepsy symptom onset and diagnosis. Another fact is that in the study, it was seen that 86% people reported that narcolepsy is a life-changing disease. 4 in 5 said that living with narcolepsy is a daily struggle. And 76 people in that study said that they avoid gatherings. And 37 people said that reported that they have failed in the class because of it. Almost everyone said that there more need to be done for narcolepsy, because interestingly, like 40% said that they do not usually discuss with their healthcare providers how narcolepsy affects their daily lives. And 94% said that they need new treatments. Just a little thing that I've found, that World Narcolepsy Day is 22nd of September, in which they walk and spread awareness about narcolepsy. Now, coming to the quiz, just a little quiz. So I need the audience participation in this. Maybe you can use the chat box or just speak out. I just want to make sure that no one is taking short naps right now. So a little quiz. A 20-year-old male present to the clinic complaining of feeling tired during the day. He is concerned that his grades in school have worsened and he does not want to lose his scholarship. Upon further questioning, the patient described frequent experiencing a dream-like state before falling asleep and waking up. He also has frequent nighttime awakenings where he finds himself unable to move. He denies snoring. The patient does not drink alcohol or abuse any drugs. The patient's BMI is 21. His vitals are within normal levels. So what do you think this patient has?
Answers, question. Let's hear. What do you think?
Sorry, are you asking me?
No, I'm asking about the students.
Yes.
It's narcolepsy.
All right, correct. You're right. The last quiz is a 34-year-old man present to a primary care clinic complaining of several months of fatigue, difficulty concentrating at work. He is tired throughout the day and often falls asleep briefly at work. He sleeps for 9 hours per night, falling asleep easily, waking up several times in the middle of the night, and then having trouble waking up in the morning. Physical examination notable for obesity, large neck, a large neck circumference, the temperature is normal, vitals are normal, the BMI is 33. So what do you think the reason for his fatigue?
Obstructive
The last one.
That's right, correct.
It's good precious.
All right, thank you so much for your attention. Thank you.
Thank you. Thank you.